Bismillahirrahmanirrahim. Hello, everybody. I am Dr. Mervat Abu Gabal, Professor of Internal Medicine and Rheumatology in Shams University. Welcome to the presentation of this interesting musculoskeletal ultrasound case. I will share my screen now. Our case today is female, 35 years. She's complaining of pain and swelling at lateral part of her right ankle of 2 weeks duration, with occasional occurrence of ankle instability. No history of sport activity, no definitive history of trauma. There is drug history of analgesic intake together with local and oral non-steroidal anti-inflammatory drugs for her ankle pain. No medically significant past or family history. Her ankle examination revealed presence of mild swelling and tenderness behind and below lateral malleolus. It's very important for sonographer to be oriented or to be familiar with normal anatomy in the region that will be scanned by musculoskeletal ultrasound. So I will revise with use the normal anatomy at lateral ankle. Starting with bony skeleton, the lateral ankle, there is lower part of fibula which end by lateral malleolus. Below it, there is lateral surface of calcaneum. Above calcaneum is talus or lateral part of talus. In front of calcaneum, this cuboid bone which articulate anteriorly with the fourth and fifth base of metatarsal bone. This regarding the bony skeleton. What about soft tissue at lateral ankle? Starting with two peroneal tendons or fibularis tendon, there is peroneus longus and peroneus brevis. Muscle and tendons. This is peroneus longus muscle and its tendon. This is peroneus brevis tendon muscle with its tendon. Peroneus, as you see, peroneus longus overlie peroneus brevis. Both peroneus longus and brevis are kept in place behind lateral malleolus and are directed distally towards their insertion by two fibrous retinacula, extending transversely and to the posterior. The first is superior peroneal retinaculum, which extends from lateral malleolus till calcaneum, and the second is the inferior peroneal retinaculum, which extends from inferior extensor retinaculum down to the calcaneum. Starting with anatomy of peroneus longus or fibularis longus muscle. Fibularis longus muscle originates from head and neck of fibula, from intermuscular septum, and from lateral surface of upper two-thirds of fibula. It descends down, forming tendon, which pass behind lateral malleolus. From behind lateral malleolus, it passes on lateral aspect of calcaneum, and then it dives below a cuboid bone into groove in sole of foot to reach its insertion into medial cuneiform and first metatarsal, base of first metatarsal foot. Regarding peroneus brevis muscle, it originates from lateral surface of lower two-thirds of fibula, descend down, also forming tendon, short tendon, which passes behind lateral malleolus. Peroneus brevis muscle and tendon are applied directly on fibula, applied directly on bone. Then it passes overlying calcaneum and cuboid to reach its insertion into porosity of at the base of its metatarsal bone. Both peroneus longus and brevis are supplied by superficial peroneal nerve from common peroneal nerve from sciatic. There is a simple mnemonic to remember the nerve supply. That's fly long, superficial, fly poi. First FL belong to fibularis longus. The other FB belong to fibularis brevis. They are supplied by superficial peroneal nerve with nerve root L5S1. Regarding other soft tissue or other structures present at lateral ankle that will be bad during ultrasound scanning, there are a group of ligaments. 3 of them form what's called lateral collateral ligament of the ankle, in addition to other syndesmotic ligaments. The lateral collateral ligament is formed of 3 ligaments, as I said. The first one is the most important and is commonly injured during lateral ankle sprain. This is the anterior talofibular ligament extending from fibula or lateral malleolus till talus. The second one is the calcaneofibular ligament, which is second to be injured in ankle sprain, but less commonly than anterior talofibular ligament. It extends from fibula to calcaneum. As you see, it forms floor for peroneal tendons. The third one is the posterior talofibular ligament, which is very strong ligament, very rare to be injured, only injured when there is complete anterior dislocation of talus. The other 2 syndesmotic ligaments are the anterior and posterior tibiofibular ligaments, which extend between tibia and fibula. Now, how can we scan by ultrasound lateral ankle structures? Obviously, or sure, we will follow the ULAR guidelines for ultrasound scanning of lateral ankle, but I picked up my image from these sources or from these references. When we start ultrasound scanning of lateral ankle, at first we must position of the patient in suitable position. His position is either supine with flexion of the knee, making sole of foot directly applied on the couch or on the table, or the patient lie on contralateral side, making the medial side of the examined ankle resting directly on the table, exposing the lateral part of the ankle to be scanned by ultrasound. This is the first part to be scanned. This is the probe position. It's one end of the probe is on lateral malleolus, extending posteriorly to view this image. This is the short axis of peroneal tendon. This is the most superficial is peroneus longus tendon. It lies under cover of superior peroneal retinaculum, and the nearest or the nearer tendon to bone or to lateral malleolus is the peroneus brevis tendon, surrounded by the large peroneus brevis muscle around it. The second position is lower down, also with one end of the probe at lateral malleolus extending down and posterior till calcaneum, and the image will be like that. This is peroneus longus tendon. This is peroneus brevis tendon, which is more apparent with a smaller part of peroneus brevis muscle around it. The third position also imaging short axis of peroneal tendon is like that. This is a probe position, still examining the transverse axis of peroneal tendon, and this is the appearance. This is peroneus brevis tendon, and this is peroneus longus tendon, is separated from each other by peroneal tubercle of calcaneum. For longitudinal scan of peroneal tendon, this is a probe position above and behind lateral malleolus, extending up till biopharyngeal junction and down till insertion of the peroneus brevis tendon into fifth metatarsal, or till the peroneus longus tendon dive below cuboid bone. And this is the longitudinal image. The superficial tendon, which appear normal fibrillar structure with normal echogenicity, mostly hyperechoic. This is the peroneus longus tendon. Under it or close to bone is the longitudinal axis of peroneus brevis tendon. To complete examination of peroneal tendon, we must exclude presence of subluxation of dislocation of the tendon by examining or doing dynamic maneuver like that. By one hand, we hold the probe, so that one end of the probe at lateral malleolus, extending posteriorly, examining the short axis of the tendon, while the other hand, or asking the patient to perform resisted eversion of foot and dorsiflexion, and then watch for occurrence of dislocation or subluxation of the tendon overlying lateral malleolus to move anteriorly, or even just extension of superior peroneal retinaculum. Now, we must examine at lateral ankle by ultrasound the important ligaments. The most two important ligaments to be examined and the commonly injured during lateral ankle sprain are the anterior talofibular ligament and calcaneofibular ligament. To examine the anterior talofibular ligament, this is the probe position. The posterior end of the probe applied at the anterior edge of lateral malleolus, and it should be directed transversely parallel to the floor or parallel to the sole of foot. If we consider lateral malleolus is center of clock, we will direct the probe to position of 3 clock. And this is the image. There is fibrillar hyperechoic structure, normal structure of anterior talofibular ligament. Its thickness is about 2 millimeters. It extends between regular bone cortex of fibula and regular bone cortex of teres, and better to be examined while in plantar flexion. Again, this is the probe position transverse parallel to the floor, starting from anterior border of lateral malleolus to visualize the anterior talofibular ligament. Here it appears hypoechoic, but due to anisotropy. To visualize by ultrasound the calcaneofibular ligament, while one end of the probe on lateral malleolus, just rotate the probe clockwise to reach 5, 6, and 6 o'clock, extending between lateral malleolus and calcaneum to visualize the angulated hyperechoic fibrillar structure of calcaneofibular ligament, which extend between fibula and calcaneum. Above it lies the short axis of peroneal tendon. This is peroneus brevis, and this is peroneus longus tendons. Also, it is continuous, no loss of integrity. Its thickness is about 2 millimeters. Now we return to our patient, our female patient who complained of lateral ankle pain and mild swelling. She was referred for complete musculoskeletal examination of her ankle, starting by the right tibutalar joint. There was normal finding, subtalar joint completely normal. The medial part of examining the medial ankle joint, medial part of ankle joint or structures at medial part of ankle joint, completely normal findings. Also normal Achilles tendon and normal plantar fascia. Now, what about the lateral ankle ultrasound examination? There was abnormal structure. This abnormality is appearance of 3 parts or 3 pieces of tendon. They appear as if they are 3, but this is due to a split tear in peroneus brevis tendon. This is part of peroneus brevis. This is the second part of peroneus brevis, and through the split tear inside, herniated the peroneus longus tendon. To see magnified image, this is peroneus brevis, again peroneus brevis, and this is peroneus longus tendon herniated through the split longitudinal tear in peroneus brevis. Slightly lower down, again, there is a split tear with herniation of peroneus longus tendon, but the tendon sheath, there is hypoechoic soft tissue or hypoechoic material, which show a positive Doppler signal indicate presence of tenosynovitis of common peroneal tendon sheath. More lower, the fibrillar structure, normal fibrillar structure of calcaneofibular ligament appeared. It extends with no loss of integrity, normal thickness, not more than 2 millimeter thickness. Above it, the short axis of peroneal tendon, again, split tear in peroneus brevis with herniation of peroneus longus in between. This is a magnified image with split tear and herniation of peroneal tendon and extension completely normal hyperechoic fibrillar structure of calcaneofibular ligament. More lower, the peroneus longus tendon started to appear flattened, heterogeneous, hypoechoic with positive Doppler signal, which indicate occurrence of tendinosis of peroneus longus tendon. This is the magnified structure. Obviously, there is tendinosis of peroneus longus tendon. Now, we start to examine the most two important ligament at lateral ankle. These are the anterior tibiofibular ligament and calcaneofibular ligament by ultrasound. Starting by anterior tibiofibular ligament, this was its ultrasound appearance. It appeared a little bit hypoechoic. Its thickness was 2.2 millimeter, slightly thicker than normal, and to avoid misinterpretation of this hypoechogenicity, which may result from anisotropy, we try to manipulate the probe to adjust angle of insonation, and this was the picture. This is the anterior tibiofibular ligament. Still, there is part of it hypoechoic, together with better appearance of irregularity at distal part of lateral malleolus. Measurement at this part reveal increased thickness. It was about 2.4 millimeter, indicate there is mild thickening of anterior tibiofibular ligament and hypoechogenicity in its, but no loss of integrity. By application of Doppler ultrasound examination to anterior tibiofibular ligament, there is increased vascularity around. This is the magnified image. There is increased vascularity around with some area of hypoechogenicity. We consider this as, together with irregularity present at distal part of lateral malleolus, we consider this as grade 1 lateral sprain or grade 1 anterior tibiofibular ligament injury. Now, our case had split tear of peroneus brevis tendon with herniation and distal tendinosis with tenosynovitis of peroneus longus tendon. This was associated with grade 1 lateral ankle sprain affecting anterior tibiofibular ligament. Now, what should be the next step? We asked for MRI, but why? To grade for split peroneus brevis tendon, by use of MRI finding, split peroneus brevis tendon can be graded from 1 to 4, and this will determine the further steps in management of this split tear. In grade 1 and 2, management is usually conservative, while in grade 3 and 4, management is surgical. Mostly our patients, but depending only on ultrasound finding, may be of grade 3 split tear in peroneus brevis tendon. We refer the patient to be managed by specialists in sport injuries, especially she had a split tear in peroneal tendon. Also, despite presence of algorithm for management and treatment and for algorithm for management and treatment of split peroneus brevis tear, which depend on positivity or absence of weight bearing. If there is normal weight bearing, we can apply rest ice elevation of foot together with compression and anti-inflammatory. But if there is no weight bearing, we ask for X-ray to exclude presence of fracture. If no fracture, we can introduce physiotherapy or advise physiotherapy for the patient. If no improvement, advise immobilization with or without injection. If no improvement, we must ask for ultrasound, CT, or MRI to determine further step in management of this split tear in peroneus tendon. But I prefer to refer the patient to a specialist in sports medicine to manage this situation. Regarding her mild ankle sprain, we advised rest, ice, non-steroidal anti-inflammatory as the condition was very mild and grade 1. Now, what is meant by ankle sprain? Ankle sprain indicate injury to anterior tibiofibular ligament and calcaneofibular ligament, which are the most common reason for missed athletic participation. There are two types of ankle sprain: high ankle sprain affecting syndesmotic ligament with their injury, but this account for only 10% of all ankle sprain. The other type is low ankle sprain, which is more common, accounting for more than 90% of ankle sprain. It involves injury of anterior tibiofibular ligament, like in our patient, but also involve affection of calcaneofibular ligament. The most common type of trauma that results in lateral ankle sprain is occurrence of foot inversion in plantar flexion. This may be associated with other associated injuries. In our patient, there is peroneal tendon injury, but I think the primary problem in our patient is peroneal tendon tear associated with mild grade 1 tibiofibular ligament injury. Other conditions that may associate lateral ankle sprain may be osteochondral defect, may be deltoid ligament injury, may be fractures at fifth metatarsal, at calcaneum, or at talus. Low ankle sprain can be classified or graded from 1 to 3 according to presence of ligament disruption, according to presence or degree of ecchymosis and swelling, and according to pain with weight bearing. In our patient, there was no ligament disruption or discontinuity by ultrasound. There is mild clinical swelling and mild increased thickness of anterior tibiofibular ligament, and no pain with weight bearing. So we graded our patient as grade 1 anterior tibiofibular ligament injury. Now, how can we assess lateral ankle injury? Clinical assessment is essential. Also, it can be assessed by imaging. Clinical assessment is achieved by performing two important clinical tests, which are anterior drawer test and lateral and Taylor tilt test. Regarding anterior drawer test, it detects excess anterior translation or movement of tibia in relation to movement of talus, in relation to tibia. It is better to perform it with slight inversion and plantar flexion of foot. We stabilize the lower leg by one hand, while by the cup of the other hand, we grasp heel anteriorly to notice the degree of anterior translation or anterior movement of talus in relation to tibia. If there is excess anterior movement, this indicates presence of anterior tibiofibular ligament injury. Taylor tilt test is achieved while the foot is in dorsiflexion. We stabilize the lower leg by one hand, and by the other hand, perform a gentle inversion of the foot. If this inversion in comparison to the uninjured side was more than 15 degree, this means there is excess inversion. This indicates presence of injury of calcaneofibular ligament in association with anterior tibiofibular ligament. This is the clinical evaluation for lateral ankle sprain. What about imaging? It can be assessed by use of radiograph or plain X-ray, but plain X-ray is indicated according to Ottawa ankle rules. They state that X-ray is performed if there is point tenderness at lateral or medial malleolus, if there is point tenderness at navicular bone or at base of fifth metatarsal. Also, X-ray is indicated if there is loss of weight bearing for 4 steps in emergency department. This is essential to exclude presence of fracture. And this X-ray should be performed in special positions. Regarding ultrasound and MRI, it is recommended if There is persistent pain for 6 to 8 weeks following a sprain, and this is useful to evaluate presence of peroneal tendon pathology or presence of osteochondral injury or syndesmotic injury. But I think this is too late. This is because ultrasound is of low cost. It's fast examination, available, does not use ionizing radiation, allow imaging of normal anatomy, evaluate ligament integrity, and allow visualization of dynamic maneuver, which may increase visibility of tear. So no need to delay utilization of ultrasound to evaluate for lateral ankle injury or lateral ankle sprain till 6 to 8 weeks after sprain, as this may be converted to chronic lateral ankle injury or sprain with its complications. So it's better to start early by ultrasound evaluation to have an idea about the injured structure. Now, what will happen if this lateral ankle injury not treated? If not treated, this can result in chronic ankle injury, which result in persistent pain and ankle instability. Also, it can result in stretch nerve apraxia. So, proper management, early management is recommended in presence of lateral ankle injury, whatever the injured structure. This management is through either conservative management by employing RICE principle. RICE means rest, ice, compression, and elevation. Later on, after subsidence of swelling and pain, physiotherapy can be applied to improve muscle strength. If this fail or there is advanced lesion in lateral ankle injury, surgical repair is the solution. Usually after management of lateral ankle injury or ankle injury in general, patients, especially athletes, ask this question: when can I return to play? The answer is this depends on grade of sprains, syndesmotic injury, associated injury, and compliance with rehabilitation. Usually, if there is grade 1 or 2 lateral ankle sprain, the patient can return to play after 2 weeks. But if there is grade 3, he returned after a few weeks. But if there is high ankle sprain with syndesmotic injury, the patient requires several weeks to return to play and may be not able to return to play except after complete season. By the way, there is a multiple case report about peroneus brevis tendon split tear. This is one of them, published in 2014. Its topic, its title is "Split peroneus brevis tendon as unusual cause of ankle sprain, ankle pain and instability." Also, there is another case report published in 2015. Its title is Peroneus brevis attrition and longitudinal split tear without subluxation. Now you can take home message. Sonographers should be familiar with lateral ankle anatomy and potential injuries and how complicated an ankle sprain can be. Ultrasound is of low cost, fast available, does not use ionizing radiation in ankle injury. Its early use can assess ankle ligament thickness and continuity. Evaluate tendon. Also, it can evaluate tendon integrity and allow visualization of dynamic maneuver, which may increase visibility of tears. Lastly, when there is suspected localized joint region pathology, it's better to undergo focused ultrasound scanning regarding the expected or considering the expected lesion. Now, after revising the topic, please try to answer these questions. The first one is, ultrasound examination of structures behind malleoli is a little bit difficult. How can you optimize your performance? The second question is, when there is suspected localized joint region pathology, is it better to undergo focused ultrasound scanning regarding the expected lesion? The third one is it essential to perform MRI in ultrasound suspected peroneal tendon tear just for confirmation? The fourth one is possible differential diagnosis of our peroneus brevis split tear are bifurcated peroneus brevis tendon as an anatomical variation, and peroneus quartus tendon insertion. How can we differentiate? The fifth question is, do you think it's too late to perform ultrasound in ankle injury only if it persists more than 6 to 8 weeks? The last question is it wise to start management of ankle injuries of any grade by a general practitioner employing RISE protocol, or should we refer all cases to sport medicine specialists? Thank you very much for your time. I will stop sharing now. Hoping you get benefit from presentation of this interesting musculoskeletal ultrasound case. See you soon with another case of musculoskeletal or neuromuscular ultrasound. Thank you very much. I will end my meeting.